Okay, good morning, good afternoon, good evening. Welcome to today's webinar, Lost in the Data, Tackling Challenges in Outcomes Measurement and Follow-up. Next slide. So my name is Joanna Parkinson, and I'll be your moderator today. So throughout the session, we'd love to hear your thoughts and questions. You can submit questions for the presenters at any time using the Q&A function at the bottom of your screen, and we'll get to as many of them as we can after the presentation. You can also access the chat by clicking on the speech bubble, also at the bottom of your screen, just so to get the chat rolling, and we'd love to hear where you're joining us from today. So before we begin our wonderful presentation, I have just a few quick announcements about some of the exciting things going on at ICHOM. So next slide. The ICHOM annual conference is coming to Montreal, Quebec, Canada, December 7th to 9th. This year's theme is Value at Scale, AI, Outcomes, and the Future of Healthcare. Registration is now open, so book now to take advantage of our early bird prices. Next slide. So at last year's conference, we welcomed over 700 delegates from over 50 countries with diverse backgrounds in the healthcare sector, including providers, industry, academics, and patient representatives. Next slide. So this slide gives you a sneak peek of what to expect at this year's conference, which will include site visits, workshops, simulation labs, networking opportunities, and much more. And you will leave the conference having gained valuable insights into value-based healthcare. I know the Pitch Perfect was one of the most popular sessions last year. It will be back this year, but we'll be leveling it up with the Value-Based Healthcare Pitch Showdown. Next slide. So we recently launched our membership program. ICHOM membership is designed for individuals to help you deepen your expertise and strengthen your leadership in outcomes-based care. Membership gives you access to practical learning, real-world insights, global peer connections, as well as preferential member rates and priority site visit access for our upcoming conference in Montreal. You can scan the QR code or visit ichom.org/membership to join. Next slide. ICHOM accreditation is a program that aims to certify implementers of ICHOM sets as they mature in the collection of patient-centered outcomes. If interested, you can scan the QR code here or visit ichom.org/accreditation to learn more. ICHOM accreditation offers global recognition as you transition to value-based care. And here are many of the organizations around the globe that have received ICHOM accreditation so far. Next slide. All right, lastly, I'd like to bring your attention to ICHOM's liver disease patient and professional validation surveys. We are inviting people with lived experience of liver disease, as well as professionals who work in liver care, to complete these surveys for our forthcoming set. This is your chance to review the proposed outcomes, share what matters most to you, and help shape the final recommendations. All right, and now without further ado, it's my pleasure to introduce today's webinar. In today's clinical environment, measuring outcomes is essential but far from straightforward. Patients are often lost to follow-up, data remains fragmented across systems, and transforming insights into meaningful clinical action can be difficult. This session will explore practical strategies for strengthening outcomes measurement in routine care, improving patient engagement, and using data more effectively to support better decision-making and patient-centered care. Our speakers today are Dr. Carlos Carulin, Deputy Director of Clinical Performance Metrics, and Tatiana De Castro, Head of the Outcomes Management Unit at Fundación Santa Fe de Bogotá in Bogotá, Colombia. So I'll now hand it over to them.
Thank you, Gianna. You are able to see our screen? Okay.
Okay. Hello, everyone. Good morning. I've seen the chat, and there are people from all over the world. Thank you so much for the invitation, Joanna, Sofia, and all the ICHOM team. My name is Carlos Cargalen, as Joanna said. I'm the Deputy Director of Fundación Santa Fe de Bogotá, in Bogotá, Colombia, South America. So our topic today, I'm here with Tatiana de Castro. Tatiana will introduce herself. Please, Tatiana.
Hi, everyone. My name is Tatiana de Castro. I'm a clinical psychologist and right now the head of Outcomes Measurement Unit for Fundación Santa Fe de Bogotá.
Okay, a quick introduction before going to the core of this presentation, which is the loss of follow-up. But before that, I would like just to mention 2 or 3 big ideas about who we are, Fundación Santa Fe de Bogotá, and a quick review of our outcome measurement pathway. Plenty of challenges. One of those challenges that is the main topic for today is the loss to follow up. What's happening there and what's our experience in and our main concerns in measuring and the specific topic of how are we losing patients or measurements or not. So Fundación Santa Fe de Bogotá is a private non-for-profit organization, a healthcare organization. The Fundación was born in 1973, but just 10 years after we were born, we opened our first hospital. The most visible part of Fundación Santa Fe de Bogotá is the provision of acute healthcare here in Colombia. But we are another things that we do, such as population health, and also we are an academic center. So we provide so much. We provide education, pre and postgraduate in medicine and nursing and all different topics in the healthcare professions. So we've been working since 1983, and our main goal and our purpose in this life is to deliver more and better health for all, not just for Colombia, but also for the region. We attend people from all over the neighborhood, so we attend patients from Peru, for some countries in the region. Fundación Santa Fe de Bogotá, as I mentioned, our most visible part is a hospital network. On the left-hand side of the slide is one of our hospitals here in Bogotá, in the capital city of Colombia. And on your right-hand side, there are 2 other hospitals. One is in the north of Colombia, in front of the Caribbean Sea, is called Serena del Mar. Mar in Spanish is sea, so it's just in front of the Caribbean Sea. And we are planning to open the 1st of July, in 1.5 months, a new hospital in another different state here in Colombia. It's called Tatamá. So there are 3 different hospitals in 3 different cities, in 3 different regions, 3 different cultures, 3 different epidemiological profiles. So that's part of our challenges to measure health outcomes in different settings, in different cities here in Colombia. So we start to work on quality since day one. So I'm not going through all this slide, but just to mention and just to remind myself that we've been working intensively in quality since day one, and we have some international recognitions and some certification, accreditation, and all this kind of stuff. And this year, we were recognized as one of the top 250 hospitals in the world. And we are, depending the clinical condition, we are the first or the second best private hospital here in Latin America. So for us, and this is an important part for the rest of the conference, for us to measure is an act of coherence. To measure health outcomes is an act of coherence. Why? What you see in front of you is our value proposition. I know that we know that around the world, maybe this formula will have some different approaches. But here at Fundación Santa Fe, value in healthcare is our only and top priority in strategy. And we decide that value for us is the mix of these three variables: health outcomes, patient experience, and efficiency. And that's when you see this, and when we talk inside within our walls, if we have value as the only one strategy, it's not coherence to talk about health outcome and not measure them. So 5 years ago, we decided to go on health outcome measurement, and that's why we create a specific structure that Tatiana is going to talk more about it. And to measure health outcomes is not an easy task. So trying to find how to measure health outcomes, we create here at the Fundación 28 different clinical conditions. In that 28 clinical condition, we gather almost 80% of all the patients that we attend here at Fundación Santa Fe de Bogotá. And you can see the ICHOM logo, just meaning that on those specific clinical conditions, we are using ICHOM sets. Not at 100% of them. I mean, not the whole set, because we have some problems, some issues here in Colombia about validation of some scales or some specific health outcome measures. So that's why we don't have sets in all the clinical conditions. And we decide, as I mentioned before, to create a specific health outcomes measurement unit. Tatiana is the head of this unit within my area. So we decided 5 years ago to create, and right now we have 7 people on that unit. There are 6 nurses and Tatiana, which is the coordinator. She's a clinical psychologist, as she mentioned before, and their mission is just measure and analyze health outcomes. We don't go in process indicators or structural indicators. They are good. There are some other people here at Fundación measuring process indicator. This unit is devoted just to measure health outcomes. And today we measured almost 400 outcomes indicators. 26% of those 400 outcomes indicators are PROMs, and almost 74 of those indicators are clinical reported outcome measures. So we've been measuring those indicators in a gradual process. I mean, we didn't start with 400 indicators 5 years ago. We started with a small group of indicators, 20 or 25 indicators, but in these 5 years, we've been opening new clinical conditions to measure, and right now we have 400 indicators. We decided 5 years ago that our approach to measurement, to measure outcomes, is we need to measure outcomes in 5 different dimensions. The clinical side, that are the traditional clinical outcomes, but also we measure functional outcomes, mental health outcomes, perceived health status, and I think
Sexuality.
1.5 years ago we started with a new dimension that is sexuality and body image for 2 specific clinical conditions: breast cancers and prostate cancer. We are measuring this sexuality and body image just in those 2 clinical conditions. So for us, outcome measurement is in the core and in the center and in the heart of our value strategy. That's why we're measuring health outcomes. So the role of the ICHOM sets, as I mentioned before, as you see a lot of ICHOM logo, we are measuring in these different clinical conditions, or we are using these different ICHOM sets. As you can see, that's the percentage of adoption of the whole set in every clinical condition. And as mentioned before, we are not at 100% in each one of those because we have some technical issues such as validation of those specific scales in Spanish and in Colombia. So that's why we are not using the whole set of ICHOM. So I think this is my last slide, Tatiana. I just wanted to go quickly up through what Fundación Santa Fe de Bogotá is and why are we measuring health outcomes. So Tatiana will present what's the next ideas in this conference.
Thank you, Dr. Carlos. As he mentioned, we've been running this outcomes measurements unit almost 5 years ago within a roadmap that has where we have faced 40 challenges or more. And that if I simplify it, we can group them in 3 big phases. The first one is the design phase, where we had to figure out what outcomes to measure, with which instruments, which were the clinical profiles we need to measure, and so on. But then it goes all the implementation phase, where basically we have to deal with the day-to-day challenges of integrating outcomes measurement to the routine care. And this is engaging the clinicians, engaging the patients, standardizing processes, reviewing constantly the quality of the data. And since 2024, we've been in the impact phase. That is basically what are we doing with the data we already have when it is a robust sample size. And here is we communicate our outcomes data to the stakeholders. We analyze and track loss to follow-up rates, financial valuation of our outcomes, virtuous value cycles, and so on. But along all this big roadmap, we understood that we have to get right 2 things in a priority. The first one was that we needed to create a dedicated outcome specific infrastructure, digital infrastructure. So we created 3 outcome specific IT tools. One for collecting the outcomes, and this system is called Tu Recuperación, or Your Recovery in English, designed for activating the patients that are eligible for measurements or outcomes measurements, then scheduling all their measurements plan, measuring the outcomes itself, and it's a repository for their analysis purposes. Then we have an outcomes analysis dashboard that is as a broad level. We can see how are our outcomes performed against different benchmark, either internal or external, and a loss to follow-up rates dashboard where we monitor our loss to follow-up and response rates that we are going to talk today. This was one of the things we needed to resolve. And the other one was that we needed to have a clear prompts collection process. And we defined two key factors. The first one, we needed to be multimodal. We collect our prompts by phone call, in person, electronic medical abstraction, depending on the outcomes category. But also, we needed to be a longitudinal follow-up. And this means that we measure outcomes not just in the acute phase, but we designed an outcomes journey, especially to mirror the patient's journey and walk alongside with the patients in all the phases of their care, not just the acute one. As a social responsibility, we believe we had to do it. And with these two things resolved, then we are going to focus in this moment in the loss to follow-up rate, because it has been one of the biggest challenges we've faced. And it has been a big challenge because we understood that it was very important, as loss to follow-up rates reduce sample size. So when we start to realize this, and I'm going to, we start to realize that we needed to say to the stakeholders, okay, we need to wait a minute, or wait 1 year, so the sample size is effectively robust to tell you or share you reliable outcomes. So this is very important for this reason, but also for staff planning, as we can see how the loss to follow-up rates varies across the staff team. We can distribute more fairly the workload, and also because it makes the process of outcomes measurement actionable. Because when we identify clear patterns and causes of loss to follow-up rates, then we need it, and we can clearly detect when something is off the record and clearly intervene it. And just a kind but unsuggested reminder, we realized the importance of loss to follow-up in the third year of our measurement. But we suggest that if you're on this, take it into account since the first day.
Okay. Richard is asking us, how is collection system related to existing electronic health record? Go back to this slide. Okay. Tatiana mentioned that we have to develop some specific informatic ecosystems, as we call. Specifically, we have 3 different ecosystems. They are not embedded within the electronic health record. One of those challenges that we faced so many years ago is that our health information system is not designed to collect health outcomes. They are designed to collect so much information about the patient, treatments, and so on, but they are not designed to collect and gather some information about health outcomes. So that's why we have to create these specific electronic ecosystems. There are some kind of links between our electronic health records and these different ecosystems, that they gather information from the electronic health record, such as demographic information of the patient, the diseases, the treatments, and so on. But they are, in short words, our collection of health outcomes are not gathered within the electronic health record. So if anyone here wants to know something about the measures of the health outcomes of a specific clinical condition, they can go to one of those specific health ecosystems.
Okay. And when we understood the importance of measuring loss to follow-up rates, then we developed a dynamic dashboard that is the one that we are going to dig in today. It has the main purpose of tracking the loss to follow up and analyzing it with 4 views that basically respond to 4 questions every outcomes program should be asking. For example, what is our follow-up rate? The first view. Thus, in the second place, how does it vary by different dimensions? Why this is happening? Why our patients are losing? And which are the patients that we are losing? And I'll go with you through each of these. What is our loss to follow-up rate? In the first place, we define it as the ineffective measurements due to follow-up barriers over the total measurements expected to be completed in the measurements plan of a patient. And the first thing that this dashboard shows us is the overall loss to follow-up rate. That is 24.8 within the 28 clinical conditions Dr. Carlos mentioned. But if I want to know only how is the loss to follow-up rate of one clinical conditions, for example, here colorectal cancer, then I can see it is 30% and start to recognize differences between the clinical conditions, because one thing that is clear is loss to follow-up rate is not uniform, it varies. And how it varies? It varies by 5 different key factors. The measurement modality, if it's telephone or in person, or medical abstraction, the outcomes category, if clinical rated, PROM, functional, follow-up frequency, if we follow the patient, as you see in the outcomes journey, only in a short term after discharge, or in a long term, 1 year, 5 years after discharge. Then measurement type, if we have outcomes that are questionnaire based, that are related to prompts, and those indicator based, and by the outcome collector, who is the member of the team that is measuring the outcomes. And all these 5 factors we can see by in an overall perspective or in a specific clinical condition perspective. So let's see some examples. Measurement modality in the overall, it's known that the patients or the greater loss to follow-ups are in those that are telephone measurements, extraction from external repositories, that this is basically unstructured databases from some services that are not dedicated to outcomes measurement, and mixed modalities. And unsurprisingly, the extraction from clinical record is the one that has less loss to follow up. But this is the overall perspective. We can see an example of hematologic cancer that has a loss to follow-up rate of 28. Remember, our global loss to follow-up is 24. And the pattern is the same. Mixed measurements and telephone measurements are the one with the greatest loss to follow-up. And when we start to see these patterns, it's easy to know where to intervene. Where do we have to make some strategies to mitigate this loss to follow-up? But then we can also see how our loss to follow-up rate varies since outcome category. Remember the 5 dimensions that Dr. Carlos told about our outcomes measurement approach: the clinical, perceived health status, functional, mental health, and sexuality and body image. Well, it's very notorious that in the clinical rated outcomes are the ones that has less loss to follow up, but the prompts in those 4 dimensions are the ones that have a greater loss to follow up, rounding the 40%. this in the global perspective, but in the specific clinical conditions such as spine diseases, for example, we can see the same. Clinical rated outcomes, 0 losses, and perceived health status, functional outcomes, and mental health, around 30% of loss. Time is another important dimension. We can see that as you go further, the acute phase, the admission phase, then the loss to follow-up rate tends to go up. So in conditions like neurovascular diseases, stroke, that we follow the patient until or up to 90 days after their discharge, the loss to follow-up is relatively stable. But in clinical conditions such as burn injuries, where we follow patients up to 1 year after their discharge, the loss to follow-up rate at 1 year goes up to 60%. Remember, the global is 24, but 1 year after, it is 60 in this clinical condition, for example. Other important variable for loss to follow-up rate variance is the measurement type. We have questionnaire-based, as I mentioned, and indicator-based outcomes, and those questionnaire-based are more vulnerable to loss to follow-up rates. And here we start to mix the different things. The questionnaire-based are usually prompts, and as you saw in the previous slides, prompts have a greater loss to follow-up rates. So I'm going to dig in the questionnaire-based ERTC QLQC30 that we use to measure quality of life across different 7 types of cancer. We can see the overall loss to follow-up rate of this questionnaire is 35%, but we have the ability to go deeper and see how this questionnaire varies in loss to follow-up within the different cancers, colorectal, hematological, lung cancer, pancreatic cancer, and also by the different segments, if they receive chemotherapy or radiotherapy, or if there are surgical treatment. And this varies, not only 35, but since 28 until 42%. And another very interesting data of our dashboard is that we are able to see how our loss to follow-up rate varies by the outcome data collector. So, for example, if I select myself, Tatiana Castro, I can see how is my loss to follow-up rate. My general loss to follow-up rate is 30%. And these are the conditions I manage in the outcomes measurement, and I can see how is my loss to follow-up rate in the different conditions. This is very interesting for us because it has allowed to staffing planning, to performance accountability, and also to addressing workloads barriers. Because, for example, if there's a data collector that has only clinical rated conditions with no losses, is not so fair from those data collectors that have only prompt-based outcomes and have more losses and have more workloads. So it's very interesting for this. And you may be asking, why are these patients lost to follow-up? We now know what is our loss to follow-up rate. We now know how does it vary by different dimensions, but why? And the top 5 reasons that represent the 85% of our losses are because the scale is not applied by the clinician or not recorded in the agreed source, because we are unable to establish communication with the patient repeatedly postponed the call, or even the patient didn't answer it in any attempt the call, or refuses measurements, or failed to attend the specialist follow-up that was in charge of that measurement. And we can step back and group these 5 reasons in 3 different issues. The first one is adherence, either from clinicians and from patient, plus the barriers that we have in our health systems to access health services. The lack of confidence, people are not sharing data with unfamiliar phones, are not answering unfamiliar phones. It is an increasing worry to scam, and this affects our response rates. But also outcomes fatigue. Patients receive too many calls, too many requests. We are not the only area in the hospital that call the patients. Patients receive calls from to confirm their medical appointments from the patient experience area, so definitely they can feel overwhelmed when especially outcomes are questionnaires are long in some cases. And what happens with those that are excluded from the measurement? It's very important not to mix up loss to follow-up rates with exclusions, because there are some patients that simply cannot be measured because of lack of consent, because of death, because of clinical reasons, and these are not losses. These are patients that are not eligible for measurements, and that's why we decided to separate them as the exclusion rate, defined as the ineffective measurements due to ineligibility over the total measurements. We have at this moment an exclusion rate of 5.3%, and is mainly because of mortality that we can't measure these patients. And now, which are the patients we are losing? This we are able to go all the way down in this dashboard to a patient's level detail. It's very awesome because, for example, we have this central nervous system patient. Here you can find all his measurement plan, and you can find the measurement status, if a measurement is unsuccessful, is pending, or is successful. And if it's unsuccessful or a loss to follow up, you can find the reason of that loss to follow up. So for example, in this patient, the Karnofsky performance status scale of 6 months post discharge was lost because patient refuses measurement. And digging in this individual patient level has allowed us to make a more deep analysis and to start analyzing and correlating these patterns of loss to follow up patients with their comorbidities or their severity or different individual variables. And you may be asking, okay, we have all these insights. What are you doing with this knowledge? We have strategies in two levels, like operational strategies and cultural strategies. In the operational side, we activate every day electronic alerts for follow-ups to the outcomes collectors to mitigate the losses, but also we ensure consistent communication with our patients. We made them at least 6 contact attempts, as Dr. Carlos said, we are dedicated 24/7 to measure outcomes. So we need then not to lose as much as possible. And we are now in a pilot phases of 3 different new strategies for improving response rates that are implementing omnichannel approaches with WhatsApp, because we, as I told you, we only do it in person or telephone, but we want to implement also WhatsApp or a mail and so on. But we are also starting to use pre-call reminders for patients. And we're exploring the possibility of incorporating AI virtual agents. It's a future project.
I think we are one slide away, but before I close with general conclusions and go to the Q&A section, there is one. Go back to the slide of the patient journey and the patient measurement, Tatiana, because there is one question here. Okay, there is one question here. It's from Jenny. How do we reach the patients? I mean, I think why did you explain what happened when a patient go and is activated in one specific clinical condition, and how all this activation activates the whole journey of measurement for that specific, and how do we reach the patient through what kind of ways? So what's our strategies?
Okay, so I'm going to go back here. We, in this outcome collection system to recuperación, we know what patient is new in the institution with a specific diagnosis of a clinical conditions. So, for example, which patient yesterday is admitted at Fundación Santa Fe de Bogotá for a stroke. Then we activate it. We activate the patient, and this activation schedules and measurements planned for 30 days, 90 days after discharge, and the baseline measurements. And this outcome collection systems has a module that is called the For Today module, that an outcomes collector can go in and say, okay, today I have to measure baseline, for example, baseline ranking modified scale to that patient. So if the patient is in hospital, the outcome collector goes directly to the patient's bed and applies the scale. But if it's an ambulatory condition like respiratory condition, then the outcome collector calls the patient. And this is the same in the different frequencies of measurement. At 30 days, at 90 days, we call the patient to measure the outcomes. That's, I don't know if I answered the question.
Yes. Richard is asking if there are some conditions more worthy in this measurement journey. I mean, for us, all the 28 different clinical condition is the same thing in terms of importance. Okay, so because as I mentioned before, there are 80% of the patients and 80% of our income is on those 28 different clinical conditions. So there is not a more important clinical condition than other, but Richard and community, there are some clinical conditions that we focus when we see some kind of loss to follow up. Basically, there are some clinical conditions with few patients by year, such as lung cancer or such as breast cancer. So we attend more than 2,000 pregnant women by year here. So if we lose 10% of those women, that's not a big deal. That's not a tragedy. But if we lose 10% of measurement in breast cancer or in lung cancer, that's a huge percentage, or it's a huge number of patients in that specific clinical condition. So when we see that we are losing patients on those specific clinical condition, as I mentioned, with few patients by year, we focus and we try to analyze why are we losing patients on those specific clinical conditions.
So I continue. Okay.
Sorry.
And we were talking about the strategies for improving response rates. These are the operational strategies, the ones that I just mentioned, but then we have also cultural strategies. We collaborate with clinicians all the time. We engage clinicians, we share them their outcomes very frequently, and that we have seen that motivates clinicians because they can see their work in numbers. reflected in numbers, and this gives them another perspective to take decisions and to continue to engage and adhere the measurements. And also, we reinforce every time the clinical teams on the good documentation strategies for having good and reliable results as well. And then I'm going to share you the stage, Dr. Carlos, for the closing
there are a
messages.
couple of questions here before these closing messages. Hamed is asking about the platform. I assume that's the technological platform for collecting all these things. Go back to our three different ecosystems. Sorry to go back and forth in the presentation, but it's important. As we mentioned, we have we have to develop in-house, Ahmed. There is not any commercial softwares for this. We have to develop in-house, tailored to our specific needs, those three different health information ecosystems. As Tatiana mentioned, on the left side, you have the ecosystem where all the data about patients and all their measures are gathered and put in this one. That's called Tu Recuperación, Your Healing in English. And that's the ecosystem that all the 6 nurses and Tatiana herself uses every day to collect and gather the information for the measures every day. In the center, there is a brand new ecosystem that we created just to track the performance of each clinical condition and each one of those 400 different health outcomes. What's happening in the day-to-day basis with the collection of data in those different clinical conditions. And the third one in your right-hand side is an ecosystem just to measure the loss to follow-up. It's quite important. So somebody, I think that is Magda, I think, is asking why it's important for us all this strategy to loss to follow up. What's important to measure the loss to follow up, and basically because we are not alone in this journey. So the board of directors of our organization ask for this measurement every 3 months. Twice a month, we have a general meeting, which is headed for our CEO. And there are all the directors of the organization and all the clinical leaders or the clinical teams. So they are asking about how is our strategy, how is going on, how are we behaving, our performance in the health outcomes measurement, how are we benchmarking with other institutions. So the loss to follow up is important because we have to raise our hands and say, give me 6 months, because we don't have the whole sample, the whole statistical sample for measuring that, because we have a specific percentage of measurements that we are losing in our journey. But also, Tatiana has to deal with the human resources planning of her team, and they have to track what's happening in each one of those clinical conditions and what's happening with each one of those 6 nurses that are collecting data. And one strategy is to see the loss to follow up and what's happening there and why somebody is losing more patients than another one, and trying to figure out how to solve this this specific thing, that losing patients in one specific clinical condition or one specific nurse. So that's why we're measuring the loss to follow up. So the last slide, I'm not seeing.
Sorry.
Maria Eugenia, a great friend, is asking about tu recuperación is completed by patients.
No.
The answer, as much as I understand, Maria Eugenia, is no. Tu recuperación is completed by the 6 nurses and Tatiana. They gather the information and they put the information in tu recuperación. So our closing messages, just to open the Q&A section, is one thing, it sounds simple, even full, to say this, but if you are going to measure health outcomes, you are going to lose patients. I haven't seen the first organization in the world that is collecting health outcomes and not losing patients. So that's something that you have to expect. And that's something that you have, as Tatiana showed us, you have to expect that maybe there are some clinical conditions and some strategies and some kind of different scales that maybe you are going to lose more patients than in others. The loss to follow up happens for many reasons, and follows some kind of patterns, such as time, such as the strategy to collecting, such as the type of patients, such as so many variables. And that's important to understand why we are losing patients and what are the reasons we are losing patients. Also, the third one is measuring the loss to follow up sets management expectation. As I mentioned before, when you sit with the clinical leaders and they ask you for their outcomes, you have to set expectation and say, I can give you that answer in 3 or 6 months, because you are a low patient clinical condition and we are losing 25% of your patients. So we expect that in 3 months or 6 months, we have the whole sample for doing some statistical analysis. The loss to follow up also enables early detection of deviation for timely corrective action. So our non-ask advice is to start as soon as possible. You start your strategy for health outcomes measurement. Also, as I've mentioned so many times, if you measure the loss to follow up, you also are saying to the people, to your clinical teams, your CEO, your board of directors, that you are not ready in this moment to measure and analyze the data, because you don't have the sample. And lastly, basically, we strongly believe that this is a central core strategy in the whole picture of health outcome measurement. I mean, if you're measuring health outcomes, is extremely important that you measure also what's happening with the patient that do not want to answer for any reason. One thing that I can remember if Tatiana mentioned is that we as a Fundación, as a hospital, as a health network, we have so many different strategies to follow up the patient. So we call the patient, we reach the patient, but also people that measure PREMS also reach the patient, but the people from infectious, the committee also reach the patient and ask the patient about the surgical thing. And there are 21 different clinical care centers calling the patient. So it's an advice as well that just see the whole picture of how many times the patient is reached for the organization, and they cause some kind of fatigue in the patient. So the patient, some from time to time, told us that they are fed up, sorry the expression, with so many phone calls and so many mails and WhatsApp. And please see the whole picture of how many times are you reaching the patient, because this also is a strong cause of losing patient and lose measurement. So I don't know if there are some questions. Here you have our mails, but let me check the Q&A section. Tatiana.
Yes, thank you, Carlos and Tatiana, for that very interesting and insightful presentation. So we have some more questions in the Q&A, and please continue to submit any questions you have. If you put a question in the chat, it might get lost, so it's best to just pop it into the Q&A so we can keep track. So the first question I have for you is about the prompts collection platform. So did you think about bringing in outside resources to build the prompts collection survey, and why did you decide to create it yourself?
Okay. The most honest question, the answer is we didn't go out and try to ask to some vendors if they have these kind of things. We tried with two specific enterprises, but it was so much expensive for us, and it was also the planning phase was too long, and we realized that maybe it was better if we design our own health platform, and that's the only reason. So we have a department of digital transformation, and they produce some softwares, and they produce some clinical ecosystems. So it was, I'm not saying that it was easy, it wasn't fast enough either, but we decided to create it in-house. There is one question here about quite a nice question, Tatiana, from Martina. Martina, oh my God, I lost Martina. Martina, do you adopt any imputation methods to compensate for missing data?
Okay, we adopt for research purposes. In one study that we are developing, we have not published it already, that is from postpartum depression. We made an imputation that process to missing data. Yes, but it's not a frequent like strategy that we have for all our conditions. We have only used it in statistical purposes for research papers in one today.
And there is also here a nice question from oh my God, this one. If we ask the patients if they are willing to fill the surveys and be able to contact in the future, That's a nice
Yes.
question, because that's also a challenge that we faced.
That we have. In the first phases of our outcomes measurement roadmap, we have a conversation with the legal team, and we developed a speech for all patients to introduce the measurements, preserving all the ethical and legal issues. And we start to respond the answer. We normally start to introduce the surveys to the patient with this speech that is legally protected, for saying in a way. And the most common answers or objections are that is too long, because the surveys, for example, a burn patient, you don't only measure the expectations of their wound, you measure also anxiety with the GAT7, depression with PHQ-9, quality of life with EQ5,
QC.
no, E5, the EORT, and that is a 20-minute phone call. So many patients is like, okay, it's too long, I'm not going to answer that.
Yes, and also it was a need that we have a few years ago, and that's why Tatiana mentioned that we have to create a specific format with the help of our legal department. But also, when the patient come here in their acute phase, there are some kind of informed consent. I don't know if the same expression in everywhere. An informed consent that the patients, we explain that consent, and the patient sign this consent to that he or she will be able to attend any forthcoming phone call or WhatsApp or another strategy that we have.
Thank you. So the next question I'm going to ask is, did you make an analysis based on socio-demographics such as age? It might bring up important information, and you might be able to focus strategies based on their age range or other socio-demographic groups.
Yes, we once we made an analysis by socio-demographic factors, and we found that patients in the adult phase, like 45 years and beyond, are the ones that are more lost to follow up in between 45 and 65 year, the adult phase. That is the working phase, the working age, sorry. So that has sense for us. That's the analysis.
Yes. We also
And the women
yes, and also by type of insurance. We attend, so our big percentage of patients that we attend here at Fundación are from private insurers, but we also have a small portion of patients that are from another kind of insurers that we call the basic insurance here in Colombia. So for burn patients, we made an analysis based on that factor of what kind of insurance the patient had, and the result was that the outcomes are not different between the type of insurance. That is a good news for us, because in our DNA we strongly believe that it doesn't important.
Like all patients should receive the same attention.
The same level of quality. Yes.
But regarding loss to follow-up rates, the patients that are more probable to lose or are the working age patients in age dimension, and women, that we analyzed that.
Have you looked at different patient outcomes for those lost to follow-up versus those who are followed up on? Is there any differences in the patient outcomes between those groups?
No, we haven't answered that question yet.
Okay.
That's a good question. That's a homework for us.
Okay. So next question, is it that if treatment has been successful, the patient disengages from the clinical engagement process and then becomes lost to follow-up simply because they want to move on from being a patient? This seems to happen, especially in plastic cosmetic surgery. Do you have any insight on if that might be a reason why some patients are lost to follow-up?
Sorry, I don't understand the question.
So if this is for about the longer term follow-up, if the treatment has been successful, do you think some patients just want to disengage and move on from being a patient, and therefore they don't want to have those longer term follow-ups?
I think it's more by social barriers to access health. I think it's more in that way. I don't know. What do you think, Dr. Carlos?
Could be, yes.
And the outcomes fatigue we already mentioned.
So somebody is asking about PREMS. When I say we, my direction, my area, we didn't collect PREMS. That's another area. That's a client service area. They have a team, a basic team, but they use an external source for gathering PREMS, such as patient satisfaction and net promoter score, CSAT, and all this kind of PREMS.
And it is very much bigger. It's 42 or 50% the PREMS area.
So, but also we are now, when I say now, it is in the last previous year, trying to integrate the PREMS and the health outcomes in one view for saying something. We are trying to gather the information that they are analyzing and integrate, just to see or just to say to our different stakeholders, we do or we perform very well on the clinical or in the functional or in the mental health side, but also the patient is saying to us that we are behaving in a more human way to them.
What strategies do you use to motivate clinicians to follow the dashboard and act to increase response rates?
Okay, we go with them like twice a year in a one-to-one or one-on-one meeting, and sit with them and share them how they are performing in the different outcomes that they select. Because when we figure out what outcomes to measure, we do it not by ourselves. We do it with the clinician. The clinician tells us, for me, it's very important to know how the patient is in this outcome. And then when we have a robust sample size, we sit with that clinician and tell him, okay, you said you wanted to measure this, then here are your numbers. And that's like, wow, it's impressive for them. And that motivates them to continue documenting well the different outcomes, and to follow also dashboards that we have. For example, it's very important for them to medical conferences. They use them a lot.
Yes, remember that we're an academic institution, so they have our clinical teams have to provide education to students, provide education through academic sessions, also attend different congresses, around the world. So when they see how are they performing, measured not by the usual process indicators, but outcomes indicators, they really believe that this some kind of numbers that are really great for them. So they use it for those purposes.
Okay. Next question. So, Admiral efforts to follow up and reduce loss to follow up. What is your ROI calculation to determine at what point the effort is worth it or not?
Okay, I we don't
So-
have that calculation. I don't know.
What's the euro? Okay. No, we don't
Yeah.
have a return of investment calculation. No, we don't have. We calculate we have done some work in monetize the outcomes. What I'm saying, that we have, when we measure and we have some performance, and we measure the performance of our institution in one specific health outcome, and we compare that performance with a benchmark that we found in the literature or in the web. So what are we doing with the 15 different health outcomes last year is try to figure out how much money do we save because our performance, and what's the money that we save, not just to our insurers, but also we can extrapolate that information to the whole Colombian population. How much are we saving because of our performance when we are compared with an external benchmark? That's the thing that we are doing. But the classic return of investment, we have not going there, because this is collecting health outcomes is costly. It's quite a lot of money. People, technology, maintenance is quite a lot of money. But this is the core of our strategy. So we cannot decide our strategy in this specific topic, based on monetary investment. So we have to do it. No matter how much it costs, we have to do it.
How big is the patient population you collect this data for?
Okay.
Is patient. We have like 50,000 unique patients measured until today, since the 4.5 year that we launched the outcomes measurement unit. It's a big population.
So the next question, ICHOM standard sets are composed of multiple proms. And during the study design phase, there is often a trade-off between distributing each prom separately, which may reduce patient burden, but risks incomplete or inconsistent responses across proms and time points, or creating a single master questionnaire containing all proms, which ensures standardized collection, but may become too burdensome and negatively impact completion rates. So how do you usually approach this balance in practice?
We measure prompts separately. We know that there are like promise where we can collect a lot of dimensions in only one questionnaire, but in this time we are measuring them separately to analyze them in a more accurate way. But we know, like, to know exactly how is the anxiety outcome, how is the depression outcome, how is the quality of life. But we know that the trade-off of this separate approach is that we can create an outcomes fatigue for the patients. So in new clinical conditions, we're taking this into account. So the less the questionnaires, that is the approach that we choose. And also because these questionnaires that are all in one, most of them are not validated in Colombia, for example, or standardized to or validated to Spanish at least. And for us, it's very important that they have these validation standards.
Okay, so next question. So it would be interesting to understand your workflow as a data outcome collector. How do you reach the patients and how are you integrated into the clinical workflow?
Okay, so as I mentioned, I know when a patient is admitted for a clinical condition, and I know all the treatment process that the patient is going to follow. So before the patient is going to surgery, I go to the bed of the patient and ask a baseline measurement. Then I know when the patient is discharged, and I make a phone call to reapply the different measurements that I have for that condition. And then I know when patients are returning either to Fundación Santa Fe or other insurance in a standardized follow-ups like 3 months, 6 months to 12 months for different follow-up appointments, and I call them to measure the outcomes. And if we found some outcomes measurements that are off the record or at risk, then we alert this to the clinician or the nurses in charge of that clinical condition, so that the clinician can have it into account in their medical appointments, and we can do something with the patients. We are truly believe that our purpose is not only measure and that's it, but we are making a lot of efforts in doing something, taking action with that measurements, and returning patients again to us for continuing their care, integral care. Mhm. That's
Okay, so there's a question here about the modalities to measure your outcomes. So if you use more than one modality to measure, are you able to minimize this by integrating more than two modalities?
this is
If we use more than one.
How is this by integrating more than two modalities?
I have to confess that
No.
I don't understand the question.
If we more than one modality.
I think it's getting at the different modalities you have for collecting the data, and asking if you think integrating them into one single modality may minimize long-term losses to follow-up.
Okay.
I think it would in the way you have more modalities, you're able to reduce loss to follow-up is what we have seen, but it's not so possible to have only one modality because patients are here in the hospital, but then we cannot reach them. For example, for a in-person only modality, we have to mix it with a telephone modality necessarily.
And it also that's a great question, because it also depends on what outcome are you
Yes.
are you asking for. The classic example is, remember that we measure sexuality and body image for two different cancers. That kind of questions for us we believe that it's impossible to be answered by WhatsApp. That's that it's so critical, it's so sensible, the different questions that you are asking to the patient, that you have a well-trained person such as Tatiana to call the patient and explain why are they going to discuss. I can't imagine to use WhatsApp or emails or something else for asking those specific and sensible questions. So it's not the short answer is we do not believe that there are just one specific a silver bullet for measuring all the different health outcomes.
Thank you. Have you published any written studies using any of this data?
Pardon me?
Sorry?
Have you published any like papers or written studies, articles using any of this data?
Okay.
And
no.
No.
We are on that process. We
Okay.
have 6 papers that we are writing. There is
the
one
manuscript.
Yes, there is one, I think, accepted in one journal, but we are in this process.
Okay, great. Well, I'll look forward to reading those. Do you alert clinicians and act on results even at the longer term follow-up time points? For example, the 1 to 2 years post-surgery.
Yes, we alert clinicians when no matter the time point we are measuring. We alert if we see something off the record in the patient's results. And also, we are developing 6 pilot projects that are called the virtuous value cycles. That is for some specific outcomes like mental health outcomes when they are at risk. Then we give to the patient specific and tailored educational strategies, but also more medical appointments to return them to us and complete their value cycle with us. Because, we are in Colombia, that is a fragmented health system, and patients usually go to other insurance after discharge. So this project is with the purpose of bringing them with us.
But just for those patients that are at risk of something, such as postpartum depression, for example. When Tatiana see and identify a patient with at risk of postpartum depression or suicidal intentions for that depression, we call the patients and we take the patient back to the hospital and put on the mental health department, and they follow up the patient that are at risk.
Do you have any de-identified data sets that you are able to share?
No, we don't have that kind of data sets. We are, I forgot, we are collaborating with ICHOM in the breast cancer initiative.
Collaborative, yes.
I forgot. Sorry for that. Tatiana, please expand this idea, because we are sharing that information for that specific project led by ICHOM.
Yes, we are in the initial phases. We recently joined the Breast Cancer Collaborative, and we are making all the efforts to have the Reno platform so that we can share our outcomes measurement in breast cancer specifically with this collaborative.
Yes, in the same line, we don't have a specific data sets, but if you are interested in our webpage, Fundación webpage, I don't know if you can write it in the chat, Tatiana. We have, or if you can copy the link.
The link, yeah.
There is an open, publicly published information
Of our
about
outcomes.
our health outcomes
Mhm.
in, I don't know, almost 20 different clinical conditions, and with different and compared against external reference. So you can go to our webpage and you can uh, navigate through that specific section, and you can find our results for different health
Health
outcomes.
Yes.
I don't know how many health outcomes do we have published.
Rounding the 70s.
Okay.
Mhm.
Okay. No, more than
Or
100.
more like 100. Yeah.
Yeah.
More
That's
or less.
plenty of information on that specific link.
Mhm.
Okay, so we just have a few minutes left. So I have one last question I'll ask both of you. So what is one piece of advice you would give to providers who are beginning the process of implementing ICHOM sets?
How many hours do we have to answer that question? I think that the ICHOM sets for us is a strategic piece of information. Every time that we want to open a new clinical condition, and every time we have to convince stakeholders that we have to measure. So sets for us is a critical discussion every time that we want uh, to measure or to open a new um, clinical condition. So that's a huge advantage using ICHOM standard sets, because you've done the hard work in gathering the best evidence, the best possible evidence that are published with a huge group of experts. So the knowledge curve is easier for us, because we find the information so much fast for using and deciding the health outcomes that are the most important health outcomes to use in a specific condition. So it's a critical part every time that we do this discussion about what are we going to measure.
And I'll give another advice to have from the beginning the clear pathway of how are you going to analyze the data, because that was something that we developed or realized in the track, but it should be very interesting to develop on time those IT tools that are very important to have a track of our outcomes performance.
The only weakness about iTunes sets for us in Latin America, we are almost 400 million Spanish speaking here in Latin America, is that not all the scales are validated to Spanish. That's the thing that we are dealing every day, because we found some nice scales to measure, but there are no validation in Spanish. So that's something that we have to work here. Sorry, in Latin America.
Well, thank you so much for this amazing presentation and sharing all the amazing work that you're doing in Bogota. Just before we end here, just to let everyone know, our next webinar is taking place on June 25th, and it will examine transforming HIV care through VBHC, real-world evidence from South Africa. So you can register by visiting the ICHOM website. So thank you so much for joining us. today, and we'll see you all next time.
Joanna,
Thank you.
Sophia, thank you so much for your support
you.
and for this invitation. Thank you so much.
Thank you.
Thank
Bye.
you. Bye.